Now, when we're talking about the skin system, the infants and children have thinner, more elastic skin. The collagen is a little bit more significant in regards to where we're at with the epidermis and the dermis. They have a larger body surface area versus their weight, and they have less fatty tissue in most cases. This can allow some exposure to temperature extremes actually harm your patient in regards to hypothermia and then dehydration, and then how bad a burn can be. Going into metabolic differences, again, infants and children have much less glycogen stores, and remember that the adult body carries most of its glycogen in muscle tissue. That's where its glycogen stores are generally kept, and so because children don't normally have a significant amount of muscle mass, they are usually not able to carry that extra glycogen, and for the most part, most children are not carrying excessive adipose tissue. After being a baby and toddlering, they will tend to thin out as they're using those excess calories to grow. So we really don't have a whole lot of reserves, and this can become an issue for us when children are sick. Now, in regards to the hypovolemia and the electrolyte derangements, this is really true because when children are vomiting or they have significant diarrhea, they are losing a lot of water, and this can cause severe shifts in the electrolyte balances. So we want to make sure that anytime that we hear that a child has had prolonged vomiting or diarrhea, that we're giving them some kind of fluid bolus because they are going to be dehydrated, and we are going to see some kind of effects of those electrolyte imbalances. Make sure that we're keeping the child warm because they're really having a hard time kind of doing it themselves. Again, most small children don't have a great ability to shiver or the muscle mass to kind of help them kind of regulate body temperature. It goes without saying that you want to rely on the parent or the caregiver to give as much history as you can get. Make sure that you're doing your appropriate scene size up, and this means that you're going to modify your assessment based on the age or the interaction capabilities of the child, and then you're going to collect any information that you can before you get there because you want to be primed on your way to the call for what it is that you need to do. This is that pre-game, so to speak, so that you can kind of not get caught off guard when you walk up on scene. Have a plan is really where we're going with this, is create that plan of attack and how you're going to try to get the information or prepare yourself for the treatments that are appropriate for that age bracket. All right, so in regards to the primary survey, we're going to use the pediatric assessment triangle to kind of form that general impression. This is very much like an adult. When you're dealing with an adult, you're kind of doing that across the room impression where you're looking at LOC on an adult and then just generally getting a good skin condition, whether or not they have some kind of trauma or bleed, and then what their respiratory pattern is, because the respiratory pattern at all tells you that they have a pulse. So we're looking for these things. And in a child, this is a little bit different, but it kind of segues into the same thing. And it should easily be done in the first 15 to 30 seconds. And this is before you come in and you start doing your actual observations of your ABCs or your CABs. So as promised, we have that pediatric assessment triangle, and here's the elements. We have that appearance, and then we have the work of breathing and the circulation to skin. So the appearances, are they lethargic? Are they actually alert to your presence? Are they acting appropriate to your appearance to them? Are they withdrawing at an appropriate time and age, or are they so lethargic that they actually just don't care that you're there? We're looking at that work of breathing. We want to know, what is that respiratory rate? Does it look like they're having a hard time? Are they using accessory muscles? Is their head bobbing or some kind of belly breathing going on when they shouldn't be doing that? And then again, do we have the cyanosis to the face, the hands, and the feet, which are usually the first things that become cyanotic before we start getting mottling, and then we start getting real pale and cyanotic all the way through the extremities with mottling to the core. You can use the Tickles mnemonic, which is tone, interactiveness, consolability, look or gaze, and speech or cry. And this is just something that will kind of come natural for you. This is very much kind of like when I'm teaching the AEIOU tips. It's just a way for you to get yourself through a process and kind of have a checklist, and that's going to give you your general appearance. So as you look at this picture here on the side of the slide here, this should be very easy for you to cue in. If you're looking between the pecs, you can see that there is a substernal retraction just at the level of the sternum. Right, this child is probably doing significant belly breathing, and if you just look at their face, they look to be extremely lethargic. That child does not look alert with bright, glassy eyes, right? He looks like he's ready to go to sleep, and you can see in just a still shot that there's a lot of work here going on. Again, the kind of same thing. We've got that diaphragm kind of retraction where the belly's pulling in underneath the rib cage. This child is not looking at the camera or anything like that. They're just intently focused on what it is that they're trying to do, and that's breathing. And so for looking at this characteristic of work of breathing, we're looking for abnormal airway sounds. This is the snoring, muffled or hoarse speech, stridor, grunting, or wheezing. So take a look at the characteristics for work of breathing. These are all things that you should look at, and these are telling you the telltale signs of a child that is in significant respiratory distress. As I've mentioned before, that modeling look you can see in the legs here where we've kind of got that, almost looks like really fatty kind of hamburger meat where we've got very pale sections with reddish striations coming through, and there may be some significant cyanosis everywhere. And as this slide is telling you, this reflects the overall status of the core circulation. Are we shunting to the core, or are we still capable of perfusing all the extremities and that tissue? The pallor of the skin and the mucous membranes is going to tell you that there's a poor circulation that's only visible in compensated shock, because when we get to that modeling, we're way late in the shock game. Okay, in regards to cyanosis, I just want you to take a minute, read the slide, and then just understand what it's actually telling you. And again, this is never wait for somebody to become cyanotic before you're going to give them oxygen. Look at your patient and treat your patient. If they're having a difficult time breathing, they are already giving you the cue that they need a little assistance, and that could just be supplemental oxygen or ventilatory assistance as well. And this should be a no-brainer. If we're getting to a point where we're waiting for somebody to get that dusky look or kind of mottled look, we've done them no favors. Okay, so stay or go. If you guys ask me, it's always go. I only stay as long as I need to either stabilize an extremity or something that needs to be stabilized to get them on the gurney, or to get the information that I have to have so that I can do an appropriate turnover. That never means that I'm staying so long that I'm, getting way deep into the weeds on things. If your patient is stable enough to get yourself some additional information, that's fine, stay there. But just try to get away from the idea that we're staying and playing, or we're going to treat on scene. Like, that's just not appropriate. 911 wasn't initiated because they wanted you to hang out in their living room and watch the Wheel of Fortune. Hands-on ABCs are just like any other hands-on ABCs, right? We have A, airway, B, breathing, C, circulation, D, disability, and then E, exposure. Anytime that we're going through it, if we have a medical call, it usually starts out as ABC, and if we have a traumatic call, it's CAB, because we're looking for the bleed and we're trying to stop the bleed. If you can't see a bleed, then we know that the airway has to be the priority, because we want to make sure that it's open and patent so that they can do their respiratory thing. Nothing different here from an adult. We're looking at an infant or a child. We're looking to see if they're responsive and if their airway's open and clear, and then look for the respiratory rate and then the adequacy. So do they have a respiratory rate that appears to be normal for their age, and does it look like that it's an adequate tidal volume? If they're breathing rapidly and deeply, then we know we have an issue. If they're breathing very slowly and very shallowly, we know we have a problem, and that's things that we can fix. If they're unresponsive, make sure that their airway is clear and that they're not with some kind of obstruction. And then if there's no trauma, it's just like an adult head tilt, chin lift. And then if they have some kind of trauma suspected, we're going into a jaw thrust. If they are unresponsive, we're going to do least invasive to most invasive, which would end up being with an NPA if you carry the appropriate size, all the way down to an OPA in if it truly unresponsive supraglottic airway. Okay, this is just a slide that's got a couple of pictures when we're checking for that femoral pulse, the brachial pulse, and the carotid pulse. If you guys are looking at this, you can see where the telltale places are to get these kind of pulses on infants, and that's the brachial or the femoral. And anything that's older than an infant, we're really just going to go to a radial or a carotid. And so you're going to have to be the judge of that. It's really difficult to find a radial pulse on a infant or a toddler. So generally, the first thing that I'm going for is a brachial on them. Very rarely am I reaching for a femoral pulse, but if I don't or cannot find a brachial, I'm going to go there and then last try to go to a carotid, because generally most very small children kind of have a lot of fat around the neck, and it can actually be fairly difficult to get a good carotid pulse on them. Okay, so in this slide we're talking about cap refill, and cap refill is really great to kind of estimate what the actual peripheral vasculature is doing and whether or not we're perfusing that end tissue. So again, we're looking at the fingernail beds. You can actually use the gums in the mouth to kind of help you figure this out. Or we can use the toes as well. So just remember, it's a quick, gentle kind of squeeze, and then we're looking to see how quickly that skin goes back to its original color. We would say pink or whatever shade of skin that your particular patient has. And again, one of the easy ways to do this is to kind of push against the gums and then see what they're doing as well. All right, so here's that FACES pain scale that we were talking about. And when we have small children that don't have a really great kind of vocabulary, you're going to talk to them in the appropriate manner, and we're going to allow them to do the Wong-Baker FACES scale. And this is just basically letting them kind of point to where they feel like this particular pain is going on. So remember, this is not a telltale or a foolproof way to go about business. You should obviously always be looking at your patient's grimace themselves, but this can generally kind of get you into a ballpark to see what their perception of their actual complaint is. Now in this slide, we're talking about making that transport decision, and again, we really want to know what the capabilities are. You should always stop if you're unable to make it, or you actually have such an unstable child that you need to stop at your first facility. But really, we should always be looking at what the most appropriate facility is. So the way I'm going to have you kind of think about this one is, if you're going to a facility and the first one that you show up to doesn't actually have the capabilities that you need, and your patient is stable enough to make it to the one that's, say, 10 minutes further down the road, if you stop at the first one because you just want to get somewhere and kind of hand the child off, even though you were capable of dealing with it for those couple extra minutes, you have now delayed that definitive care. And that could be upwards of an hour. So you bring a child to a physician that's not really qualified to deal with this issue. They're going to work as hard as they can to get them stabilized and probably get some consultation over the phone. And then they have to get that child packaged in a stable kind of situation to get them re-transported again. And this is where we get those inter-facility transports. So again, I caution any of you, don't take the easy way out, which might be the closest facility. Always try to consider what the best thing is for your patient and get them to the most appropriate facility, so long as you can do it safely. Okay, in regards to securing patients that are pediatric size, and this is any child that's, say, like under 100 pounds, again, gurneys and ambulances were really not kind of developed or built around the pediatric patient. Now, there are often some kind of jump seats built into the captain's seat in the back of an ambulance, but the actual gurney itself was not developed for a child or a pediatric patient. And so this is where we have to look into alternative means of transportation. Long spine boards are kind of on their way out. This isn't something that's really nationally recognized very often anymore. We're very rarely utilizing them for anything more than extricating a patient if we need to. So that's kind of off the radar right now. But we may have a child that requires some kind of splinting. They're not going to fit in that jump seat or the car seat. So this is something that you should talk to with your service that you're working with, and try to come up with some kind of solution for pediatric transport. This is actually kind of a specialty, and without the right equipment, we can actually end up hurting our patient if we get into some kind of unintended kind of traffic accident or something else happens. Okay, in regards to taking history with your child patient or the pediatric patient, remember that language can be very much exclusionary. This is why you have to actually understand appropriate medical terminology, but you have to use the appropriate terminology with a patient who does not have the vocabulary of the normal layperson, much less the vocabulary that you're going to use with your coworkers and peers. Okay, really quickly on investigating chief complaints, just remember that your approach to history taking really depends on the age of the patient, and oftentimes is going to be very appropriate to be done with the parents or the caregivers. When we have teenage children or children that are able to be, we'll say, sexually active and reproductively viable, we will obviously want to ask about sexual activity and the possibility of pregnancy if it pertains to some kind of issue that's going on, right? We really want to kind of find that out on our female patients of any reproductive age, just for the case of any kind of surgical intervention or even all the way down to x-rays. But again, they may be very hesitant to have that conversation with you, so don't push excessively to try to get that information. In regards to drug or alcohol use, this is, again, another one of those things where there may be some shame that's involved in there, and they may not want to be very willing or forthcoming with that information. So you're going to have to kind of use kid gloves to try to get that back out of that patient. Now, in regards to parents or caregivers, obviously there's quite a few circumstances where they're not going to be able to ride in the back of the rig with you, although if it's possible, we would like to have them in the back because they're usually really great at helping us get the information or giving us information that we need. If they are actually unable to do so, make sure that you get a name and a good contact phone number. Almost everybody has a mobile now, so that when you get to the facility that your destination is, that you are able to get that information across to the receiving facility, and they can allow mom to come back or dad to come back in, whomever that might be, and then we're on the same page. So we don't have an unattended minor in the facility or with you for prolonged contact. Okay, in regards to the secondary assessment, this is a slide that I'm going to just basically disagree with. I feel that any time that you're doing a secondary assessment, this can always be done in the privacy of the back of the rig. For the most part, you can get into the back of the rig and you've got several minutes to get this done. A secondary assessment does not take a lot of time for you to kind of do that head-to-toe assessment analysis of body systems. This really doesn't need to be done on a street corner or in a living room when we could be making our way to the appropriate facility. So remember, it's a full body exam. You're using DCAP BTLS, looking for any kind of things that are unusual or should not be where they are. If you're dealing with infants, toddlers, and preschool children, we're going to work our way up towards them. We're going to use the extremities first and try to get in towards the core, right? Remember that they're generally going to be a little bit more shy, and they're going to want to withdraw from you. So if you get into their personal space right out of the gate, you're probably going to have a little bit of an issue trying to get a good full assessment. We're working on gaining their trust and slowly showing them that we don't mean any real harm to them. So that's going to be kind of a reverse. Instead of where we have an older child or an adult, we're usually right up at, into the face, going down from the face, the neck, along the core before we get to the extremities. So nothing new here. This is all the same stuff that you're doing on an adult. We're looking at head, pupils, nose, ears, mouth, neck, chest, back, abdomen, extremities. We're going to check cap refill. This is where you would take maybe a secondary set of pulses as well. And then checking the level of hydration. And this is where, do we have adequate skin turgor? We're going to do this on elderly patients as well. We're going to kind of gently pinch up at the skin, and we're going to see how quickly it responds or goes back to its normal shape. Okay, and we're going to say it yet again, infants and children have a real hard time compensating for respiratory problems. Again, when we have that kind of different kind of anatomy, and by different I mean just the aspect ratios or the kind of structural changes, we can get into harm's way really quickly with them. So make sure that you are doing your best to get in front of that and then determine what the actual severity of this disease process is. These are all your typical signs of respiratory distress. This is nothing new to any of you. We've already talked about this several times throughout the lecture so far. So please read down the list and make sure that you kind of know that and get it kind of stuck in your head as part of your pediatric assessment triangle for work of breathing. Now we're talking about those signs of impending respiratory